Greetings, Patho students, and welcome to week 3, Integrative Body Functions. Our chapters are chapter 8, 9, and 10 with an emphasis. I always tell you which of those chapters to emphasize. Emphasis on chapter 8, which is disorders of fluid, electrolyte, and acid-base imbalance. Chapter 9 is stress and adaptation. Chapter 10 is disorders of nutritional status, which also for some reason includes some eating disorders, which sound more like, I feel like those are categorized as psychiatric disorders. But anyway, we'll just touch on those a bit. As I say, emphasis on chapter 8. During week 3, a case study. You have done, many of you, not all, but many of you have done one practice case study. This is going to be a real case study that is worth points for you. And you'll find it on Canvas in week 3, and you'll answer it right in Canvas with text boxes or whatever, the way you did before. So let me emphasize, I think I put some comments on some people's practice case study because it was practice. It wasn't worth any points. But I did give you some feedback. If you go to the grade book, you should be able to open up little comments. So I'm not looking for cutting and pasting or copying and pasting of material from your textbook to answer these questions. I'm looking for you to answer the questions in your own words. If you prefer to annotate your answers where you found your answers in the book, then that's fine too, and I appreciate that. That's a good habit to get into. But I'm not looking for, this is not an exercise of copying and pasting, okay? So if that is the way you answer your questions in the case study, you're going to lose points for that. So in order for you to get full points, I want you to answer in your own words. Not necessary to elaborate, just answer the question and do it in your own words so that you're demonstrating that you have a sense of understanding. Also, at the end of week 3, you have your first exam. It's called course exam number 1. You're going to find it in Lippincott under Prep U, and it'll be labeled course exam number 1. It's going to open Sunday at the end of week 3, so that would be the last day of week 3, and then it remains open until Tuesday. Open Sunday at 6 a.m., closes Tuesday at 10 p.m. For the exact dates, refer to your course schedule that's attached to your syllabus or to Canvas. So let's get into what to focus on in these chapters 8, 9, and 10. Chapter 8, as I said, is I think your most important and where there's most content that I need you to take from it. Some of you have never had any clinical experience, so you may be slightly overwhelmed when we start talking about lab values. But this is a time for you to begin exposing yourself to, you're going to have to memorize. This is just memory. There's a nice table in chapter 8. It's the first table, right in one of the first pages. It's table 8-1. And it's got the norms of all of the electrolytes. I'm telling you the most important ones that I want you to focus on are sodium, potassium, of course bicarb, because we need bicarb when we're interpreting blood gases. So we're going to have a little introduction into interpretation of blood gases. Know that we measure electrolytes in a unit called milliequivalents, and that's small m, capital E, Q, / capital L, liter, milliequivalents per liter. And what we're measuring, what those numbers represent, are extracellular concentration of those electrolytes. So we have intracellular presence of all those electrolytes. We can't measure those. We don't get into the cell to measure those. But we get a relative idea of what those concentrations are by measuring the extracellular concentrations, which we find in the serum. So we take a blood test, stick a needle in your arm, venipuncture, take out the blood, and we're measuring the concentration, let's say sodium. We're measuring the concentration of sodium in the extracellular fluid. So that's just to get you a little bit started on what we call the units of measurement and how we come to those numbers. So starting with the distribution of body fluids, our functional compartments are pretty easy. It's intracellular compartments inside the cell and extracellular compartments outside the cell. And then the extracellular is divided up even further. And we'll get into that. You need to know about the concept of edema. Edema is a problem with fluid distribution, and it results in accumulation of fluid within the interstitial spaces. Your book does a nice job on page 162 of kind of trying to explain what the interstitial space is. I think of it as extracellular space outside the capillaries. So we refer to interstitial tissue, we refer to interstitial fluid. And a fluid can be both pushed into the interstitial space, and it can also be pulled into the interstitial space. And your book says it comprises about 14% of your body's fluid. So edema is back again to edema. It is a problem. We don't like to have edema. It's a bad thing. And it means that there is inefficient pumping of fluid throughout the body for some reason. Sometimes it's a result of injury. Sometimes it's a result of some kind of a disorder. But it's too much fluid in interstitial space, and it results in swelling. That's our clinical manifestation of edema. It can be caused by arterial dilation, by some kind of venous or possibly lymphatic obstruction, where there's a dam happening in the flow of fluid. It can be caused by increased fluid volume, or it can be caused by increased capillary permeability. So those walls that are supposed to hold everything in have weakened in some way and allowed fluid to escape. And we also, I said we look at it and measure it in clinical by swelling. Weight gain is also an indicator of edema. And that is why so many of our patients have a doctor's order to have daily weights taken. We're not thinking that they're gaining weight in the hospital. We're monitoring their fluid volume by doing daily weights. So I told you we're going to look at several electrolytes. I want you to review the concept of osmosis and diffusion. This chapter does a good explanation of osmosis. Basically, it's molecules seeking equilibrium, and that happens by fluid moving across a capillary membrane, for instance. That's a semi-permeable membrane, in order to achieve equilibrium on both sides. And then diffusion, you might have to go back to chapter 1 for a better explanation of diffusion. But basically you'll find that it's substances or ions that move from areas of greater concentration to lesser concentration. So the substances themselves are trying to equilibrate. So I mentioned that sodium was one of our important electrolytes. And again, the measurements that you'll see on table 8.1 are extracellular quantities of sodium. So if you were to see a question that would say, what is the chief extracellular ion or electrolyte? Just look at that table. Look at the numbers. Which of those electrolytes is most abundant in the extracellular tissue? It's sodium, right? The normal levels are 135 to 145 milliequivalents per liter. So then another question might be, what is the chief intracellular electrolyte? Again, look at that table. The answer to that is potassium. So We are still measuring extracellular potassium, but you see how the number is very different, like 3.5 to 5.0, where we have 135 to 145 milliequivalents per liter of sodium. Extracellularly, potassium, we have 3.5 to 5.0. So what does that tell you? Where is most of our potassium? Very little of it is in the extracellular fluid. Most of it is in the intracellular fluid. Excuse me, intracellular. It's inside the cell, and that's where it belongs. The other thing to note is the ranges. So when you see an electrolyte like sodium, which is 135 to 145, so let's say your sodium is 131 or 148. Because that number is larger, we don't get so excited. But with potassium, when you have such a small range, your number is 3.0 when normal is 3.5, we get very excited. You need some potassium supplement immediately, probably intravenously. So that would be called hypokalemia. Hypokalemia, insufficient potassium. We think of sodium as being related to water. So one easy way to remember this is just the word salt water, sodium, salt, and water. That as sodium rises, so too might water. So you'd get a patient possibly in a situation with excess fluid volume because of excess sodium intake. In Chapter 7, we're going to get into cardiovascular disorders, chiefly hypertension. Very often our first approach to manage a patient with hypertension is to restrict their dietary sodium. If we restrict dietary sodium, we might also cause excess fluid to be peed out, basically. There's quite a few factors that I need you to pay attention to when we're talking about sodium and water in this chapter. One is ADH, or antidiuretic hormone, that is signaled by the pituitary. That's also known as vasopressin. That can regulate your sense of thirst. The other is aldosterone, which is produced by the adrenal cortex. Aldosterone loves salt, loves water. So if you have too much aldosterone, then your body's going to be holding on to sodium, holding on to water. The others are renin and angiotensin. Renin is an enzyme, an enzyme produced by the kidneys, and angiotensin is produced by the lungs. And both of those promote the secretion of aldosterone. So I'm actually going to put a graphic up on Canvas. It's called the renin angiotensin aldosterone system. It's sometimes called the RAS or the RAAS, two A's for angiotensin and aldosterone. I would love it if you would print this out. It's in color. Put it in a page protector. Put it under your pillow at night. You're going to refer to it over and over again because it affects so many disorders in our body. And once you really understand how this system works, you're going to have a step up on understanding so many other disorders. Before we get too ahead of ourselves, you also need to refer to the terms isotonic, hypotonic, and hypertonic. And there is, in your book figure 8-3, it has 3 test tubes, one with isotonic fluid, hypo, and hyper. They drop a cell into each one and it shows you what happens to a cell. So when we talk about IV fluids, for instance, we typically will infuse an isotonic solution. So 2 examples of isotonic solution are what we call normal saline, which is 0.9% sodium chloride. So 0.9%, so that's less than 1% salt in water. That is isotonic. We put that into a patient's veins, and it's not going to disturb the integrity of the cells. You won't have cells shrinking, you won't have cells exploding as you do in those examples in figure or table, I guess it's a figure 8-3. Then anything, so we've got normal saline and we've got D5W, so that's 5% dextrose in water, also considered isotonic. The problem with D5W, we don't see it that often in the hospital. Normal saline, very common. The problem with D5W is it is isotonic in the bag, and we're infusing it, but sugar, it's sugar. Sugar does not stay circulating. Sugar is going to go into the cell. So as soon as the sugar is escorted into the cell with insulin, then you're left with just water. So water by itself is considered hypotonic, and you'll see in that figure what happens to cells in hypotonic solution. There are some situations where it is preferred to infuse a hypotonic solution, and there are others where it is preferred to infuse a hypertonic solution. We're not going to get into all of those, but know that an isotonic solution is that which lives freely among the cells and does no damage to the cell integrity. Okay, moving on, we're going to hit on just a few of the disorders of too little of these electrolytes, too much of these electrolytes. So if we have insufficient sodium, if those serum sodium numbers are dangerously less than 135, let's say milliequivalents per liter, we call that hyponatremia. That is insufficient sodium. I want you to look at table 8-4. And so what I want you to get from your reading is, what are the signs and symptoms of hyponatremia? What are the signs and symptoms of hypernatremia? And what can we sometimes do to correct those? In some cases, these electrolyte imbalances can actually be lethal. So it's very important that we, as practitioners, of course, we know the numbers of what normal is, and then we know what to do if they're too high or too low. Same thing with too little or too much of potassium. So potassium, the symbol for potassium is K, capital K, with a positive, a mark after it. So too little potassium is hypokalemia. So you can remember the K, it's spelled with a K, kalemia, and hyperkalemia, too much potassium. So that would be table 8.5. How does the patient present, and what are the precautions when we have to infuse potassium to correct a hypokalemic situation? What are the precautions we have to use when administering potassium? If you watch enough medical shows, you'll remember that in some cases you can actually kill someone by direct injection of potassium. It stops the heart, and in some movies, that's been the weapon of destruction, is an injection of potassium. So on to another electrolyte, which is calcium. Know that calcium and vitamin D kind of go hand in hand, and that it is the parathyroid gland that helps to regulate our levels of calcium. The parathyroid glands sit on top of your thyroid glands. They're like tiny little raisins that sit on top of your thyroid glands. And they're part of our endocrine system, which operate by negative feedback. So read about the effects of too little or too much calcium and how we make that in most cases, we make the diagnosis by lab, But when it comes to calcium, there's actually some physical assessment signs that we can pick up if we don't have access to lab results or if we're still waiting for those lab results to come back. And then do the same thing for magnesium. So I'm asking you to look at sodium, potassium, calcium, and magnesium. Okay, this is an overview of acid-base, getting into the end of Chapter 8. Depending on where you are in the nursing program, if you are still in the queue waiting to get in, this may be your first introduction to acid-base. I don't know if they teach it in physiology or chemistry. They teach it in chemistry. So maybe it's not your first introduction, but you will, it'll be a reintroduction, and you will be coming back to acid-base quite frequently. And you'll hit it hard in Block 4, where you actually have to interpret blood gas results and define whether or not this is a situation where there's compensation going on or not. I don't care that you know about that. I care that you are able to look at a pH and a CO2, and in some cases a bicarb, and determine whether this is a respiratory situation or a metabolic situation, and whether or not you're looking at a patient in acidosis or alkalosis. So in general, we say that it is the concentration of hydrogen ions that affect our acid-base balance. So when we measure them, there's actually an inverse or reverse relationship. So if we have a superabundance of hydrogen ions or too many hydrogen ions, we have a low pH, which gives us an acidotic state. If we have a decrease in hydrogen ions, we have a high pH, which gives us an alkalotic state. So I want to say right there, it could be a bit confusing. But know that it is the concentration of hydrogen ions that we're dealing with here in acidotic or alkalotic states. And that we do have, the body does have buffer systems. And in addition to the buffer systems, we have the renal system and the respiratory system, which will work to compensate in the presence of either an acidotic or an alkalotic state. So I do want you to read about metabolic versus respiratory, acidosis and alkalosis, and refer to tables 8-10 and 11 for the signs and symptoms in the treatment of metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. I'll leave it at that. As I say, I don't expect you to determine whether or not there's compensation going on. But I would expect you to, if you're presented with a patient, for instance, with COPD, I want you to be able to link the condition, let's say respiratory acidosis, with what is the likely disorder. And of course, cardiac arrest is a likely disorder at the very end. And that can give you both respiratory acidosis and alkalosis and metabolic acidosis and alkalosis. So that's not a fair disorder to look at. For instance, DKA, diabetic ketoacidosis. Well, there's a giveaway there, right? Diabetic ketoacidosis. You know the patient's likely to be in an acidotic state, and because the patient's going into ketosis, because they have insufficient insulin. Actually, DKA is a state of type 1 diabetics who make no insulin. So not only do they have insufficient insulin, they have no insulin. So they are not metabolizing glucose at all. They're getting their carbs from other processes in the liver, for instance. Diabetic ketoacidosis, your patient is likely to be in acidosis, and if we were to look at the respiratory component of that, you'd find that possibly their CO2 was normal. It would be their bicarb that would be low, and we would call that a metabolic acidotic state. Okay, Chapter 9, stress and adaptation. And we're not just talking about the stress of a long commute or financial stressors or possibly academic stressors. We're talking about those, yes, but we're also talking in some cases of physiological stressors. Anyway, this is where we learn the actual result that stress has on our bodies. The term, homeostasis, the definition of homeostasis basically is a state where your body is looking to maintain optimal function. And how many of us can say that we're in that optimal function level at any given time? There's always something going on. Also, the term here I want you to learn about is general adaptation syndrome, which is called GAS, G-A-S, general adaptation syndrome. And those are steps that our body's going through, or stages that our body's going through in our mind to help us to bring us back to that optimum function. There's a section here midway through about PTSD, post-traumatic stress disorder, and the psychological and the physiological effects of PTSD. Also read about adaptation and coping strategies. I personally believe that our youth are not given opportunities to develop. This is my personal belief. It's not in the book. I don't believe. They're not given opportunities to develop coping strategies. So when something occurs in life, they don't know how to cope with it. And very often the choices they make can be destructive to themselves or others. I'm also reminded of a video I just saw this week of when we're talking about PTSD, the emotional support animals that airlines are cracking down on. They're very important for a lot of people. But in Newark, I think, Newark Airport, a woman tried to board a plane with her emotional support peacock that was perched on her shoulder with an 8-foot-long tail behind it. There's a picture of it on the news this week. It was just pretty unbelievable. Okay, not much in that chapter, but some important points that I want you to take out. And then chapter 10, disorders of nutritional status. As I said, this kind of goes back and forth between some what I call psych disorders and the obvious physiological values of how we store, what is a calorie, how do we store fats and carbohydrates and proteins, and how does our body use them. There's lots of discussion about obesity. You should know the definition of obesity and the relationship of obesity and inflammation. Know that if your patient is obese, there is a constant state of low-grade inflammation going on, and this is not a good thing. And this basically predisposes you or increases your risk for other illnesses. Just take a quick look at what the major causes of malnutrition and starvation are, and that's about it for this chapter. You don't need to get into the eating disorders of anorexia nervosa, bulimia, binge eating, etc., unless you're interested in those yourself. You'll come back to those when you study psych. You have a case study on fluid and electrolytes to do that you'll find in Canvas. And then at the end of this week, you have your first big exam, and you'll find that under the Prep U tab. It'll be called Course Exam Number 1. We did have a practice exam early on, and if you recall, the practice exam that I gave you was timed, and this exam will be timed as well. There will be 50 questions, so this will be a 50-minute exam. Please make sure that you're not going to be disturbed. You can't stop the exam and restart it. Once you've started, the clock is ticking. You can't exit and re-enter. So just make sure that you carve out a space and time for yourself to take this exam. And it will cover, that is chapters 1 through 10, with the emphasis on the chapters as I told you throughout the weeks. Okay, if you have any questions, please email me